cleanliness of drinking water, and so it made sense for people to drink alcohol-based drinks through the day, apparently, in order to continue surviving. And so then as we move on in history, the saloons in the Old West, actually our drinking rate, as far as a nation, increased up to 7 gallons in 1830. There were, of course, those more socially acceptable, probably a little bit more often used by women. The alcohol is sold as tonics or cures around that time. And then, alcohol and its problems, overconsumption and addiction tended to, it built into kind of a crescendo at the 1870s, and the Women's Christian Temperance Union movement was begun. The Women's Christian Temperance Union was a platform that eventually included voting rights for women. And many people say that it's not a coincidence that on the same year that women got their right to vote, prohibition was passed. It was the 18th Amendment, but then by 1933, due to all the effects that were not anticipated, in history, including, all sorts of illicit activity, and people continuing to drink just illicitly, that in 1933 it was repealed with the 21st Amendment.
There were tremendous deaths due to the illegal alcohol that was being sold at the time.
Crime, all sorts of things were happening. And so, let's see. So in 1938, Bill Wilson wrote the Big Book, and AA was born. He based some of the information and the 12 steps out of the Oxford Group 6-step program, which included self-improvement, self-inventory, admitting wrongs, making amends, prayer and meditation, and to carry the message to others. It was, just like the Women's Christian Temperance movement, based in Christianity and Western beliefs. The emphasis was on the spiritual experience and having peer support, the power of the group. The 12 steps include the following, and you can see that it is very geared toward God and Christianity. It is included in practically every step. And as AA began to gain momentum, the medical community thought that maybe there was something to this. And the Minnesota model was adopted by hospitals, and this was spread throughout the country, so that it was widely disseminated as far as the philosophy that is contained in AA. And the philosophical tenets are here. Addiction is incurable. Addicts have no control over the addiction. Addicts must surrender to a higher power. A higher power is not necessarily a Christian God, it's a higher power. And the focus is on sobriety and surrendering. Whereas the medical model is very similar that you can see. Addiction is primarily an illness. It's incurable but controllable, and it encompasses relapse. However, it was so widely disseminated that I think that we have, to this day, throughout the court system, throughout the medical system, all the philosophical tenets of AA still exist, that abstinence is the best, that harm reduction is just replacing a drug for another drug, and such beliefs as this that may or may not be helpful to our populations. Of course, AA grew over the years. It starts encompassing Narcotics Anonymous, I believe in the 60s or 70s. And there's HA, I don't know what that is, or GA, OEA, Al-Anon, Alateen, Alcoholics Anonymous for families was also developed. The idea of codependency was developed in the early 80s. And many more adaptations of the 12-step. 12-step programs, it seems, reached their height in the 80s. But it's been almost 80 years so far that we've had AA groups. And yet we look at the effectiveness for each type of population, and we find that they are most likely to be effective among white Christian males. And this does not even begin to encompass the entirety of our population in America. The types of meetings, certainly in AA, there's different types. There's closed and open. There's grapevine, living sober, promises, reflection step, BB enhanced.
That's the big book, right?
Big book, right. Speaker and discussion, steps, traditions and promises, and beginners. AA can help, but it is limited as far as who it helps. AA and its many variations have helped millions of people around the world attain long-term sobriety. The current estimates from AA are that 5 million new attendees per year go to an AA meeting. The expectation is attendance of 90 meetings in 90 days, or 3 per day, 1 per week, whatever is needed. You work on the 12-step, read the books, find a sponsor, and that sponsor helps you through the steps. And the resources are as following. AA does cooperate with the professional community, which can be problematic. Mandated attendance by the court systems will often mandate attendance to AA or NA meetings. And it's unfortunate because I think many people in AA before this practice started said that the meetings were often more productive and that many of the members would speak up and participate. And what they find is now there's sort of a few people hanging in the back of the room, not particularly wanting to talk, not particularly wanting to participate. And so it changes the dynamics of the group itself and the nature of the groups. There's people waiting at the end of every meeting, usually to get a paper signed or stamped in order to present to a judge or to their probation officer. So the difficult thing about finding exactly what works and how it works is that AA is Alcoholics Anonymous, and anonymous is the key word. So researching the effectiveness of this group and the dynamics is often very difficult. There is research, but it's limited, and when compared to the numbers of persons who have participated in the program. If you look at how many people that you may treat that have gone to at least one meeting, that's certainly something that, and maybe never gone back, it's something that's challenging. So in 2007, the Society for the Study of Addictions, the 5-year study of AA attendees, the person's attending 26.6 meetings per year. That was the average. 47% were abstinent after 5 years. But what about people who do not attend more than one meeting, or who attend for a while but then find it's not for them? What about people that only attend a few meetings per year? Other results that are listed, 33% of the members are sober for more than a decade after coming to AA. The Alcoholism Treatment Quarterly in 2000 analyzed AA surveys from 1968 to 1996, and they found that 81% stopped coming within 30 days. 90% stopped coming within 90 days. And 95% stopped coming within 1 year. So where are all these people? And how are they going to be best treated?
So let me just say, with the research on 12-step, because it is so difficult to research, to really see its effectiveness, we can't really do clinical trials of the material because of the anonymous nature of it. It's basically the saying is, it works for the people it works for. Mm-hmm. And for those that it drop out or drop out too early, we're not really clear why or what the loss is. So for those that say, I like going to meetings, 12-step is helpful to me, we want to encourage people to continue to do those things that are helpful. But we don't want to use it as a blanket or one-size-fits-all recommendation. Because obviously the data is pretty clear. A lot of people will try it, but then they don't continue.
Mm-hmm. Sounds like approximately 10% of the people who actually attend AA continue.
Right.
Which means that there's about 90% that something else may appeal to and may be more effective.
But those who attend, it seems to be helpful.
Mm-hmm. And so we thought that we'd talk about another peer-led group as an alternative that may appeal to those 90%. Or at least some of those 90%. And it's called SMART Recovery. It's self-management and recovery thinking. The first alternative to AA was founded Women for Sobriety. A large group of facilitators in 1994 split from Rational Recovery. And then SMART Recovery starts in about 2013. Recovery has more than 1,000 groups in the United States. At this point, this is a timeline. And then in 1990, the Rational Recovery was founded. In 2000, Rational Recovery had no sponsored groups.
And I think one of the interesting things that the alternative was founded by a society for women. Mm-hmm. And one of the things that the research highlights is that for the people that AA does not seem to work for, we think is part of this need to surrender, to give over your power or your agency, and that's particularly difficult for people of minority status or who have experienced disenfranchisement of some kind. Mm-hmm. So women, ethnic minorities particularly, it's very difficult, this concept of I have to surrender or give over my power, because they might feel very little power to begin with. So that major tenet is something that is very difficult particularly for women and minorities to accept. Mm-hmm. So I think that's weighed out in this timeline.
And of our population, I mean, the estimate as far as just general population of women, 1 in 3 by the time they're 18 are sexually violated in some kind of a way. Mm-hmm. I would imagine that our population we encounter probably more than half, to 60 to 70%. Of the population. So that would be even more difficult. Mm-hmm. Maybe trauma activating. SMART Recovery. There's a focus on self-empowerment. There's an emphasis on cognitive behavioral techniques. It even uses motivational enhancement interventions. It's recognized by the American Academy of Family Physicians, the Center for Healthcare Evaluation, the National Institutes of Health, the U.S. Department of Health and Human Services, and the American Society of Addiction Medicine. It is an evidence-based practice. It's not just steps that you follow. It has science behind it. They've followed and done studies on how effective it is and what is effective about it. SMART Recovery view of addiction is different than AA. It sees addictive behavior is over-involvement with substance use That is alcohol, nicotine, cocaine, heroin, food, etc. Or activities such as gambling, sexual behavior, spending, etc. So you can see it's already destigmatizing in a large way, even simply by this view of addiction. We assume that there are degrees of addictive behavior and that all individuals to some degree experience it. For some individuals, the negative consequences of addictive behavior become so great that change becomes highly desirable.
That's a pretty stark contrast to AA's view, which focuses even on the language of calling individuals with addictive behavior addicts. So the addict is incurable. The addict must surrender. Mm-hmm. And this is really, really opposite to that by just really focusing on the addictive behavior.
Mm-hmm. So there's a 4-point program. There's building and maintaining motivation to manage addictions. There's coping with urges and triggers, being able to identify them, work with them. Managing thoughts, feelings, and behaviors. And balancing short-term pleasure with long-term goals. The suggested focus was also on consequences as much as long-term goals, being able to pay attention to what's most important to you, but also being able to think about what the consequences and be able to consider alternatives and what those consequences would be, being able to make the best choice. In Smart Recovery, the decisional balance exercise is talked about. I hope that you guys are familiar with it, but it's sort of considering each area, being able to look at why I want to continue using, why I want to stop, what would be the benefits or the consequences of each. It emphasizes coping with urges. There's no evidence to support that individuals are powerless over their urges. In fact, the mind is a powerful thing. So being able to use it to change thoughts and behaviors really makes a difference as far as being able to cope with urges. Learning to tolerate distress will put you in control of your urges. So it emphasizes the emotional, being able to deal and cope with emotions in a more effective way. Urges are a normal part of recovery, not a crisis. I think oftentimes AA has a black and white view of that kind of thing. You're either using and you're lost to the winds, or you're not. You're dirty or you're clean. It's very stigmatizing, and people will often relapse for longer periods of time if they have that kind of thought. That it's either I'm using or I'm not. I'm relapsing, right? So urges are a normal part of recovery. Urges do get weaker over time. So writing out urges, learning mind surfing, things like that. An urge log, such as this, is used. You enter the date and time, rate the level of the urge, the length of time. And being able to track these things actually has quite a bit of power for people because they're able to see that, that urge that I had last week, that lasted pretty intensely, but this week it was a little less. Being able to understand triggers, tracking that, and being able to, over time, establish a good understanding of what changes in their life they may need to make. Where was I? Who was I with? How I coped with it, the alternative activities or the substitute behaviors. So being able to figure out what alternatives you could do. Also managing thoughts, feelings, and behaviors. Expose irrational beliefs that lead to using and challenge them, such as, well, if I use once, then forget it. I'm just going to relapse forever. I guess I'm a loser, right? So looking at the activating event, right? Perhaps you were around old friends. The irrational belief, I'm a loser. I'm going to keep using. I'm destined to use if I relapse even once, right? And the consequence of that irrational belief, well, you use for longer, right? Learning emotional regulation techniques, problem solving, learning relaxation, because anxiety often has a lot to do with use, and communication. Relapse is an important part of self-examination. So it gives us an opportunity to reassess. So you can see here this reframing of what a relapse would look like. AA, many people avoid going to a meeting for a long time because they don't want to have to talk about it, right? They don't want to have to go up there and talk about the last relapse or why. And instead, taking the stigma out of it and looking at it as a means of learning more. It's more information. It's a learning experience, being able to look at what was working. Okay, well, I was doing great because of these things, but that one thing happened, and being able to look at what wasn't working. So it's a way of reassessing. So you can see that Smart Recovery has a different take on things. It also integrates the CBT kind of activities, so looking at the activating event, the belief that you might have, the consequence of the irrational belief, and then disputing that irrational belief, helping people reframe their thoughts to cause different feelings and then move on to have more effective behaviors and change their thinking. So looking at a balanced life, what does a balanced life look like? It's not just emphasizing one thing, such as the addiction, right? So what would you like to see your life like? What are the steps it will take to move toward these goals? Learning to balance and appreciate emotions, and learning to live comfortably without addictive behavior. This seems that it's based in reality, but it also tends to hearken to the ACT kind of principles, being able to pay attention to your values. What's smart policy on medications? Well, this is also a point of contention quite often with AA and NA, because even psychiatric medications can be frowned upon. It seems that there's multiple studies that support medication management, being able to look at medications like naltrexone, methadone, Suboxone, Antabuse, acamprosate. All of these are legitimate medications that doctors prescribe and do help and have been proven to help with recovery. Whoops.
So SMART allows that within its model.
Right.
Yeah, it's a personal choice, and it has nothing to do with their participation in the group.
On what model of addictive behavior is SMART based? There are many models and theories about addictive behavior. Each includes certain implications for what to do to prevent and treat addictive behaviors. Smart Recovery doesn't endorse or adopt any particular model. Instead, they draw upon approaches that have scientifically been proven to work. In other words, this makes this a more flexible model. It is adaptive over time, and as the research shows more in one direction, they're likely to go in that direction. Whatever is most effective, they're likely to embrace. So most of what has been proven effective so far has come from conditioning, social learning, and cognitive models. So that's the foundation. And do they regard it as a disease? Smart recovery tools can work for someone whether or not they believe that addiction is a disease. The debate over whether addiction is a disease can be divisive and distract from a person's recovery. Using a meeting to debate this issue may alienate participants and will not help them in the recovery.
So they sort of avoid that discussion and just say, whatever you believe, you can still use these tools.
Right. So in other words, it's going to allow for many points of view. It's okay to use the term alcoholic or addict in meetings. They discourage the label. In fact, people often feel stigmatized by such labels, they say, and can interfere with recovery. If meeting participant refers to themselves as an addict or alcoholic, that's their choice, and they should not be made to feel unwelcome.
So SMART doesn't use those labels, but they say if the person chooses to use them for themselves, they're not going to discourage that.
And the belief that addictive behavior is genetic. While they say there is some evidence that genetics may be a component of addictive behavior, there's no credible evidence that suggests that's the only factor, only risk factor. And even the main one, blaming genetics can make a person feel powerless and sabotage their recovery. Many factors may play a role in the development of addictive behavior, and are, but not limited to. So they acknowledge that there's many different factors that are contributed to possibly addictive behavior. And they do not endorse AA's model where it's a disease and you are powerless to the disease. Is it okay if people talk about their religious or spiritual beliefs? So they're open to spirituality if people are, if they find this helpful. They're flexible as far as people who do not have that spirituality, that they don't necessarily have to have it in order to be progressing in SMART recovery. And this is their view on mental health issues. Many people with substance and behavior addiction suffer from other emotional and psychiatric issues. SMART can't solve every problem, so we encourage these participants to seek professional treatment and guidance of a psychiatrist, psychologist, or other mental health professional to help them deal with mental health issues. They're much more open to the possibility of psychiatric medication as well, being able to seek out what help that you might need, whatever that might be for you. And is treatment for addictive behavior essential for recovery? No. In fact, only about 30%, is that right, actually choose a place to be able to support their recovery and go into treatment. About 60% recover on their own in ways such as SMART recovery or even just by themselves. Many people recover by choosing to change their lives and relying on support already available to them. What if a participant wants to detox? Detox from certain drugs such as heroin is an unpleasant, but it isn't usually dangerous. However, detox from other substances, including alcohol, can be dangerous and fatal if done without appropriate medical supervision. Anyone who wants to stop taking a substance they're abusing should seek professional advice before they stop using. So they really support being able to use every tool that you may possibly have at hand. So consulting medical professionals, being able to get support through therapy or psychiatry. If you want to learn more about SMART recovery, it's included in the slides today. Here's the site. So here's the summary, the core components of AA, as well as the components of SMART recovery. When to use each intervention. What do you all think? I want to hear from you about what intervention might be most effective for each person that you might work with. Give me some examples. And let's discuss how 12-step and SMART recovery might fit into an integrated treatment program for substance use. What other effective methods seem to be in each model, and how would you apply this to your current position or clinical practice? So let's discuss. We're going to unmute you.
This is Clara
Hey,
in Lee
Clara.
County. We utilize in our family reunification court, formerly known as drug court, we utilize the Smart Recovery as far as through our therapist. He actually that is doing family reunification court. He's using Smart Recovery with our drug court clients, as well as they are attending AA or NA, which includes PDAP, Palmer Drug Abuse Program. And they also can attend church as a support program that they can use as their outside meetings. So here in our program for our substance abuse treatment, we do use the Smart Recovery with our clients. And I know I have the Smart Recovery that I've done with families that don't attend our family reunification. And it's been very helpful with them too.
And do you have any experience with AA as far as the model and implementing that with families?
Only encouraging them to go to AA and them talking to me about how it's been a big help for them. You know, those 12 steps, you know, knowing that that's what's kept them going. And when I see the families that I lose contact with or close the cases, and we talk about some of the things that happen to them when they've relapsed, often it's that they stop going to their meetings. And that's a big factor that they identify of why they relapse, is they stopped having that support.
Yeah, I think that's why it's good to offer a menu of choices, just like what Clara's talking about, to allow patients to select what's going to be the best mix of supports or interventions for them. Because we know that of the percentage of people that recover on their own without intervention, a lot of it is the social support, being able to access that in their community or in their family systems. And the fellowship that people get out of AA, whether they do the steps or whether they adhere to the model, the fellowship seems to be the most effective component. So if people can't access Smart Recovery or non-faith-based supports in their community, sort of talking with them, like it sounds like what Clara and her agency does, to say, well, what could you get out of accessing the support in your community? Because showing up and being around other people that are also focused on recovery has a lot of power, sort of regardless of whether you buy into the model or not. I have several atheist clients who will still go to AA and NA, and they won't maybe buy into the higher power component, but they really do get a lot out of being able to spend time with other people who are focused on recovery. So I think that's great, Claire, that you offer so many different options.
I don't know if you guys see Jackie's comment, but it says we encourage individuals to have recovery support in their lives. We have AA, NA, CA, and DTR on site. We also encourage use of Smart Recovery and also faith-based recovery groups. Celebrate Recovery, for instance, in our IOP, we want individuals to go to recovery support. Oh, it skipped, sorry. Recovery support meetings on days they are not in the program. And then Smart Recovery is difficult to access. Over time, Smart Recovery comes and goes, and this is in Albuquerque.
That's very true. I think that is a limitation. AA and NA is widely disseminated, so it's much easier to get access to one of those meetings than it is to find a Smart. I think we only have one.
We have two.
Do we have two now?
Yeah.
Okay, so it fluctuates.
It does,
but that's
as far as the
limited.
venue and right. Yep, there's none out in Rio Rancho or on the west side.
Yeah.
Marcella says, I at First Choice Community Healthcare and our MAT program use Smart Recovery, Living in Balance, and also encourage patients to seek additional treatment if needed at local AA and NA meetings as well.
That's great. And then Crystal shared with us a website for 12-step through alternative prescriptives. Oh, that's great.
Nice.
Thanks for sharing that.
Those that are interested but struggle with the traditional AA terminology.
Oh, good. So there's some alternatives to offer people. That's great to know. Yeah, it also sounds like several of you have gotten the Smart Recovery training and are able to offer that at your agencies, which I definitely encourage. I think it's easy to access that toolkit, and it's not expensive to get training and to be able to host a group at your site. So that's great to hear people are doing that. So there's more options than having to go out to the community. And it's nice to know there are alternatives for people to access the AA groups that might struggle with this sort of tradition. Anybody else have comments or questions what you're doing, how you're using these 12-step or community group models, or if there are other things out there that you found particularly helpful you can share with the group?
Delia.
Hi, this is Maureen.
I've referred members that, were doing intensive outpatient, and they had some of them were required to do 12-step, and sometimes, you kind of just get the members that are just totally turned off by the idea and say they're not going to do it, or it hasn't worked. They just get more depressed or want to use more. I've heard that a lot recently. The one person that I've had on my caseload that did do really well in a 12-step was a person with intellectual delays. And I think it was because it was like, some type of community, and she felt like part of something, and she really enjoyed like when they would give the tokens and celebrate, how much sobriety they had. But that's been my experience with the 12-step for AA.
Yeah, thanks for sharing. I think that's very, very true to the experience I've had. That for the patients it works for, it's very effective. But for others, it's especially when they're mandated. Unfortunately, we know if we mandate anyone to treatment, they're probably not gonna participate, get what they need to get out of it. So that's an unfortunate artifact, I think, of the court system sort of requiring a particular model.
Yeah.
Noreen, were you going to share something?
Yes, good morning. We have a traditional treatment that covers pretty much domestic violence, substance abuse. So we use that, and it's based on their story. We listen to them and we support them in their recovery, or even to get back in harmony with their communities, their family. And I believe that works. And there's some things that I saw in the Smart Recovery that are compatible to what we're doing, whereas AA is clashing with what we do.
Yeah,
Exactly.
So it's very directive as far as AA is concerned for me. And also there's ways for them to wiggle out of recovery as well. Thank you.
Thanks for sharing that, Noreen. That's great. You have,
You're welcome.
sounds like a very culturally a sensitive intervention for the population you serve, and you're open to integrating other components that would be compatible. But that's really great to know that that's available.
Thank you.
Did Jackie give us a comment? Let me scroll up. I think we missed Jackie, and her folks had said something.
It's like, oh, here, I
You
can
can
scroll
just
on yours.
scroll
I see mine.
Okay. Yeah. So it looks like Jackie says, in Albuquerque, it's great to have access to AA central office. Oh, that's nice. We have groups from all over the city that come into Turquoise Lodge, so patients have the opportunity to explore and experience the different perspectives on support through meetings. Love the comments about traditional methods of the current speaker. Yeah, that's really great for you to be able to bring like a tasting menu into your organization so they can get a feel for the different types of meetings or what is available in the community, and then it makes it a little less aversive to try it out on their own when you're encouraging them to go out and find a meeting that they connect with. And even though we focused on traditional AA in this, we focused on traditional AA in this lecture, which isn't always compatible with, like we said, people from more disenfranchised populations. But there is a range of different meetings. There's women-only meetings. There's atheist meetings. They've other communities have sort of taken the 12-step tradition and modified it to fit their specific population. So being able to expose people to those different options is great. So they know that there's more out there. What was the comment about?
Crystal asked if there were benzo detox centers that anybody's familiar with. What we do in ASAP is we have providers that will help someone taper off benzodiazepines, and I believe that any psychiatrist or doctor would be able to do that as long as they know what they're doing. Being able to determine how much a person is using and then help them taper off in a safe way. So we don't necessarily have to do inpatient for that, but I think that the physician needs to be experienced or at least have some support. And I'm sure our physicians would be happy to have conversations with people to consult if anybody had any questions about that.
Yes, absolutely. So I say comments about smart recovery. Jackie says, I wish we could implement smart recovery more. I agree, and I think, I hope you guys can find, those of you that don't have it or have a group at your site, to go to that toolbox and see if there's someone who could champion it on your staff and take the training. I think it's like $70 or $75. We were able to at ASAP to pay for staff to get that training to be able to run a smart recovery group. So I think it's the link, the toolbox link that was provided in the slides, or you could just Google smart recovery and it will take you to their website and then follow the instructions to get the training. And I think it's an online training, I believe. Please chime in if I'm incorrect, those of you that have done it. I believe it's an online training. And then you get access to all of the smart recovery materials that you can then implement at your site.
Hi, this is Noreen again. Could it be offered by the ECHO Zoom project?
I don't know. We should look into that because I believe it is sort of like a lot of the trainings that we do with Matrix Model and sort of the other evidence-based practices, they're sort of owned by that particular organization. So there might be some copyright stuff that they wouldn't want us to go around. If Noreen, if you didn't catch the relapse prevention presentations that we did the previous 2 times, those are available to you. A lot of the material that was provided there is in alignment with what's offered through Smart Recovery. So you could kind of take the bits and pieces if you didn't maybe have the funding to be able to get the official materials. But I'll look into that. We will ask and see if that's something that we could find out if we can purchase it and then.
Okay, thank you. I'm sorry.
That's a great question. What were the other questions that?
Maybe the application's just conversing.
Okay. Any other comments or thoughts that people have about this topic or that you'd like to share with the group?
Hi, my name is Sharon, and with our outpatient treatment center, we don't really provide AA meetings or even the Smart Recovery. But one thing that we've been looking into, and I recently went to a Celebrate Recovery training, and that's something that we would like to start up here, at the, at our treatment center. But Smart Recovery, we haven't sent anyone for training or anything like that, but I think it's something good because, especially in our area with AA meetings, I know, like you mentioned, it's not for everyone, and I think I see that a lot with the clients that I see. And some of it's very few that do get it, and the rest, they're part of that 95%, that don't go back, and they just, it was just really hard for them. And I know I have one client who went like three times a day, and she still was, she would end up drinking going over there, and it was just like, it just wasn't working for her. And she was reading the book. She was really like, I'm reading the book. What am I missing? She's like, I'm going to start from the beginning of the book again. She's going to, because she felt like she wasn't getting it.
Yeah.
And it just made it really tough for her to really understand where she was at. And I think it just
the rigid tenets of AA tend to support that kind of conclusion that unfortunately some people can come to, that it must be something wrong with me.
Right.
Yeah, that's true.
Yeah, thanks
but
for
I'm interested in the smart recovery. So
It can
thank you.
Another alternative, yeah.
Yeah, and I think it's nice because it's like it's already packaged for you, like how to run the group, what to do in every session, sort of what the tenets are. So if you're looking for something like that to implement, it's a relatively cost-effective way to have an evidence-based group model. And I know at ASAP we also don't host any 12-step meetings. We will absolutely partner with people who find that effective, and we will offer it or encourage it and give them group lists, but we don't host anything on site. And so sometimes people who've had negative experiences with group or have never tried group and are just sort of anxious about it or avoidant of it, we have a lot of groups on site, and that can be a nice transition to be able to say, we'll try it here first in the safety of the place that you're familiar with and with the people you're comfortable with. And then we can talk about what's out there in the community that might be a good fit for you. It might be AA or NA, it might be the atheist group or the women's group, or it might be Celebrate Recovery or a religious group at their local church that maybe doesn't do the full 12 steps, maybe they just do 6 of them. But once they've had that exposure, it might be a little easier for them to connect with the fellowship part and de-emphasize the big book part. Right, because sometimes that's what people are reporting as sort of the effective change agent with 12-step programs. It's not so much following the steps. It's the process of connecting with other people that are doing the same thing and being able to call them and talk with them and get really good support when they're struggling with an urge or with a slip or when they don't have that in their home. So if you can start something at your agency, have them experience some of it, then they might be more open and get more out of other community groups.
Thank you.
Yeah, no, thank you. Thank everybody for all the great work you're doing. It sounds like a lot of you have very thoughtfully put together some group programming or thinking about putting together group programming, and either are using one or both of these models or have developed, like Noreen developed her own model that's very culturally specific to the group that they work with. And I think that's awesome. I think, it's good to hear nobody's using sort of a one-size-fits-all perspective, that you're trying to create a menu for our patients so that they can really have individualized care. Anybody else? You done with your side conversation?
Yeah.
Okay.
Thanks everyone for joining us.
Yeah, thank you so much, and thank you again for everything that you do. It makes such a difference. And please feel free to reach out by email if you have any follow-up questions. And I know Kim is going to be sending the slides out, so look for that in your email to be able to access some of those links that we provided. So are we good? We're wrapping up 5 minutes early. I know. Everybody gets to go get coffee or something before your next meeting, next patient. All right, thanks everybody.